I'm really excited about the next panel, and I'll tell you why. So the next one, we're going to switch gears a little bit more into a commercial mode. And the reason why I'm so excited about this is because I get asked all the time, right? Hey, Ethan, this technology is super exciting, right? Where should we start? What should we build? And as you can see from all the amazing pilots today, often there are so many use cases. I tell people million of one things, right, to build. But I often don't see that personally to be the main roadblock. And often what's stopping a solution from really scaling, creating that sort of impact, is really more, hey, who's going to buy this and why? And so it gives me great pleasure to introduce the next panel, ROI, which AI solutions are likely to scale. We'll be with Lynne Chou, founder and managing partner, Define Ventures, Galym Imanbayev, partner, Lightspeed Venture Partners, Fabiënne, global market access manager, Bayer, Dr. Christine Nguyen, Senior Director and Medical Director, Quality Transformation, Inland Empire Health Plan, moderated by my colleague, Dr. Justin Norden, MD, MBA, founder and CEO, Qualified Health, also an adjunct professor at Stanford. Give it up for the panel.
Ethan, thank you so much for that very kind introduction. And really just thank you to the whole AIMI team. This group and the interest in this topic has grown and grown and grown over the years, and it's really testament to this group really driving these discussions. So with a little bit of preamble, Ethan, thank you for setting up the topic. We are shifting gears towards the sometimes frowned upon view, especially in academics, of where is the ROI? Where is the return on my dollars that I spend on this? We've seen amazing talks on the future of AI, where it can go, clinical questions, other pieces. Now we're going to grill the venture capitalists, and it's okay, I was one, so I can come back on where this is coming. But then also really hear from some of our industry partners on where they are seeing this success and scale. Because what I will argue and what we'll focus on for the next 20 minutes before we open it up to questions is where we can start to see that alignment in incentive and ROI. That tends to be a precursor for where we see scale and where we see adoption, which is really what we all care about if we're going to drive impacts and use these tools to really make AI care better for patients. So Lynne, I'll start with you. Give an example from a portfolio company that you're working with, which is really a shining example for what scale looks like and where AI has really kind of fundamentally reached and start to change how people are using these tools or doing a healthcare operations piece.
Absolutely. Well, thank you for having me. And I'm going to shake things up a little bit. I know we've talked about a lot of provider-facing platforms, technologies, and AI, but want to also offer another perspective. While we have many provider-facing technologies and platforms, is really on the payer side. So we actually built a company called Cohere with Humana. And just to give you an essence of the scale of this company, we are in 50 states. We are a clinical intelligence platform utilizing AI with the first focus around prior authorization. Now, don't sigh, everyone. This is to make it easier, better, more efficient, more digital in doing that. And in doing so, and when I think we focus on the right AI models, on the right kind of product and workflows, which I'll get to in a minute, we can have this kind of scale. And the scale that we've achieved thus far is we have 250 AI models undergirding our platform. We are in 50% of all active provider offices in the US, 50%. And we also have transacted over 4 billion claims as a part of this. And so that's to give you the scale. And I think some maybe also parts of this scale and why it's important. I think we focus on some core attributes when we either build a company, which we did with Humana this time, or invest in a company. Obviously team, so I'm going to put that to a side. We have a phenomenal team who's gone 0 to 1 and to where we are in scale today previously. But we think a lot about product clock speed. And I think that's really important of this era where we've really democratized the ability to build here with AI. And so teams who really can listen to a strategic customer, either if it's a provider or a payer, and really understand not only what V1 looks like, but V2, V3, V4, and can go very quickly. So we first started in musculoskeletal, we're now in cardio, we've gone to imaging, and now we run about 60% of the payer spend in prior auth through our platform because of that product clock speed. I don't think you get there, though, if you don't think about how the product is architected and how we think about workflows within both not only a payer infrastructure, but a provider infrastructure too. And because I think we've honed so deeply on that product and the workflows, we have things and we've held ourselves to a standard of NPS for providers. So our NPS score is above 65 NPS, which we're talking about prior auth software, like back to like baseline here, which we're very proud of because we're removing the friction, we're removing those operational efficiencies, but that's because we thought a lot about product and workflow. And to give you an example, early days, we brought in product leads from Instagram and from consumer companies to look at wireframes when we were building Cohere to make sure that we were building an experience that providers could utilize quickly, could digitize. So using that outside-in thinking as providers, as users of this software. And we've now achieved 3 to 10x ROI for payers and providers as we've, again, if you imagine instead of going through 8 prior auths for an MSK procedure, we can shorten that time frame and we can remove a lot of those steps and burdens because we are undergirding the clinical intelligence to make sure the right protocols are being followed and then remove the friction and burden from the system.
So we'll talk more about that, and we'll continue the payer side of the table, and we can talk at the end, or we can ask about the arms race that's happening on both sides. But Christine, you're building technology. We talked about how you're looking at ideas on the outside, but really choosing to build technology internally. What's one example of a success story at scale that is actually changing how care is delivered today?
Yeah, thanks, Justin. So one example that we've done within our organization is, when you're a payer, there are clinical outcomes that you're held against, not just, and you're graded on a national level. So one example is making sure that women who have recently delivered children have a postpartum visit in a very timely manner. If they don't do it within a certain window of 7 to 84 days, you get penalized for that. Because you're not helping that patient get the recommended care. And so, when you have a small team of people, let's say 10 people, and you have 20,000 people who are delivering throughout the year, that's very difficult for that small team to have that one-on-one interaction with 20,000 people. Because it's not just one phone call, it's probably multiple phone calls, multiple touch points. And so so we built a solution in-house to help us identify, which of these members would benefit the most from a high-touch outreach support from our very small team. Because there are some that are actually likely to go on their own. They're more engaged. We've seen it historically in their utilization. And so we've been able to reallocate some of that small team to have that higher touch support for the members of the patients who really needed that higher touch outreach. And so we've been able to increase our engagement rate by double, actually, for this performance measure. And I think all of it is not just about measure-based, but it's also making sure that the people who are needing the care receive the recommended care, because if you don't, there are actually a lot of negative consequences that can happen. And that's additional utilization and unnecessary utilization that could have been avoided in the healthcare system.
And Galym, I'll ask the same question to you. What is the shining example you think so far, maybe on the provider side, if you could give an example there for where you see scale?
Sure. Thanks, Justin. And again, I really appreciate the invitation. And AIMI has done a great job here, having been at Stanford for both undergrad, med school, business school. It's great to see Stanford finally kind of taking a very strong leadership role against some of our counterparts on the East Coast. So on my end, look, I think one of the things of a shining example, but let me color it in the perspective of how can you remove some of the nebulous kind of mystery around why certain companies succeed and certain companies don't. We've all at this point been exposed to AI scribes. Lightspeed, we led the Series C for a bridge right as it beginning to inflect. And so sometimes I feel like it is the role of the investment community, especially those with medical backgrounds that are trying to actually advance the industry, to share what happened a little bit behind the scenes. What is it that enabled this company to succeed where there's many other really good teams, well-intentioned teams that just haven't had that same escape velocity? And I will just share two things. One, the back preface is this is quite a unique technology that we might probably not be able to see something of this fast adoption. But the two things that I'll just leave the group, because and the whole intention of this is to make sure that somewhere here around this room or others, people can see and realize, hey, you know, if someone's been able to do it in this category, I can do it in another category. And we need more strong founders to do that. So the two things I'll leave, one is having a very crisp, clear understanding of what are, I would say, kind of like the seismic actions a startup can make that can essentially give you unfair advantages. In the case of a bridge, they were able to position themselves as the alternative to nuance in what was otherwise very much a monopoly in the industry. If you can position yourself as truly the alternative, and they got a very special integration partnership with Epic relative to everyone else. That created a particular tailwind. Other startups just weren't thinking in such an ambitious way. And then the second is just like a very tactical thing, I would say. When we were evaluating all these AI scribes, I remember very distinctly there was a founder of one of them who was, you know, in a very, I would say, a little more pompous way, kind of bragging like, hey, I'm about to get 45-minute Zoom call with a decision maker at this really large provider enterprise. You know, impressive. I was like, very cool. And then, but Shiv was able to have 2-hour dinner with this person at their home. You know, and the question is, it's not that like, oh wow, what kind of tactical things can you get into someone's home? No. It's yeah, that's a wrong takeaway here, fellas. The thing is, what was actually high integrity motion? Shiv, over the course of years, developed a tribe of CMIOs who were thought partners, who he essentially grew up with. And then as finally a breakout moment occurred, he was able to essentially take advantage of that, but to do it in a way that is truly authentic. So those are, and the thing is, these things are not unsurmountable. I think everyone in this room could, and I would always, you know, encourage folks. There's much more sectors outside of just AI scribing. So
switching things up a little bit, Fabiënne, you're at Bayer, one of the largest, you know, medical companies in the world. You already have scale. How do you use that scale now as you want to start to bring your AI solutions to partners? How do you find budgets where they can start to actually pay for that? Because that's kind of another big gap that lots of people, whether transitioning from academic, early startups, other ways, kind of struggle to kind of find it. So how do you navigate that from scale at Bayer?
Yeah, I think this is a very important question. And the ideal answer would be if we would have, just checking if this is on, I think this is better. So the ideal answer to this would be that there would be reimbursement coverage, right? That payers would cover, like having CPT codes in place here in the US, covering these algorithms. Unfortunately, we see very few so far. So I think in general, we see typically radiology practices, hospitals paying for the AI when they're using it. Other examples we see for patients, opportunities paying for AI is patients. So even here in the US, we see examples where AI companies offer for patients to pay for AI to be used on top of the radiologist reading their imaging. Another area is the research funds, private equity here and there, and maybe one other element which I think is mentioned a couple of times in previous talks I've attended is like outcome-based agreements with vendors or outcome-based agreements with industry like Bayer. Unfortunately, I have not seen so far great examples of these. All of these as a different type of stakeholders who can potentially pay for AI have different value perceptions. And I think that's something which is really important to keep in mind. Like all of them value different use cases of AI, which makes them invest or not invest in specific areas. So it's really important to understand like each driver, barrier for specific stakeholders, what would consider them to invest in this area. So maybe just to highlight with one example, if you think about an algorithm which potentially removes the need for a biopsy, invasive liver biopsy as an example, from a patient perspective, not having to undergo such a biopsy is massive value, like not having any potential risks associated with undergoing the biopsy, major value. Also, from a payer perspective, not having to pay for such a biopsy, very valuable. if you think about it from a healthcare perspective or from the provider perspective, and although I would like to say that we pay for the outcomes we deliver, hospitals are not paid for the outcomes they deliver. So fee-for-service is the common model. So we pay for the service they provide. So if you would remove the biopsy at first, that will be a direct reduction of their revenue. All of this is important, just to name an example on what different perceptions are from different stakeholders when talking about who can budget or can pay for AI.
And thank you for switching gears. And this is, you heard some amazing success stories, that Lynne and Galym talked about of scale of these companies were able to reach. But Christine, as we were doing our prep call, you don't work with any vendors and you're building everything in-house. So this is the flip side of just how hard it is to find that budget. Could you elaborate more on that?
Yeah, so I think there are some vendors that we work with, but we also have, we're very fortunate to have a very smart team of data scientists in-house that help us build these solutions. So I don't know if any of folks in the room here, how many of you have tried to get a vendor contracting either through a health, like your health plan or your hospital provider system? And I don't know how long has that taken. I don't think it's a day. How many has been 3 months, 4 months, 5 months, 6 months? It's a very long time. It's a long time to wait, especially when your teams need that solution today or yesterday. And so there's a speed element to it. There's also a cost element to it. It's very expensive to outsource all the builds for every solution that you would need. And also there is a ramp-up period as well. After you get through the contracting phase, it takes time to get to know the people in an organization, to understand the problem that they're facing, truly understand the problem that they're facing, understand all the complexities of the data that you have available in order to build the AI model. And so we have this very great team in-house, and they've been able to have those existing relationships with the business leaders, understand some of the challenges that we're facing as an organization because we are in it together, and being able to just bypass a lot of that ramp-up period that's necessary to build those solutions.
I think it's interesting because we've actually conducted an AI survey with C-suite leaders for payers, providers, and pharma. And we actually, if you see our survey, there's a 6-layer stack. Let's say at layer 1 is GPU compute all the way up to the application layer. And we asked buy, build across that stack for both payers, providers, and pharma. And what was really interesting is it depends what part of the stack. So the majority of payers and providers wanted to partner with startups, if you will, on the application layer, but then wanted to own and to, if you will, build parts of the data lake and layer where a lot of the activity was happening. What we saw in pharma, though, was also interesting is more the pharma relative to payers and providers actually wanted to build within on the application layer. So I think we also have to talk about, Justin, what vertical we're talking to on their predilections and where we are in the stack.
Yeah, and actually, Lynne, I want to come back to you as well. We heard about budgets. We know about how hard it is based on different parts of the stack, what they want. What is something you were super excited about? You don't have to name the name of the company, but what was something where you thought it made sense, you thought it worked, but kind of this group can learn from for where they weren't able to find that budget, they weren't able to tell that ROI story, and they weren't able to kind of make it to that finish line? And what was just a couple lessons you could learn for something that thought was a good idea, seemed like it had things lined up, but didn't make it to scale?
Yeah, and I mean, maybe I would say that a lot of the AI companies that we've invested were all in that kind of journey. But I think I think it's twofold. It's both sides, I would say, and I can cite like very specific where we've brought a strategic to the table, and then the AI company. And I think what's happened, this is very interesting. This is an operational efficiency company who's doing process automation with Gen AI held together. So imagine 100-step processes, you digest an SOP, and now you can have 100% automation. You don't have to integrate into Epic and your Citrix database and your Workday or whatever database you're looking at. And to me, it's like and the strategic at that point, when we made that introduction, was like, well, wait a second, I'm not ready. Our processes aren't perfect. We have to like build perfectly. And I'm like, no, that's That's exactly the point. You don't have to be perfect in your process. You don't have to optimize it before layering on a solution like that. So I think I call it V1, V2, V3, which is for strategics, like knowing where you are in V1, where you're willing to innovate a bit, take a bit of risk, know that you might not have the ROI perfectly planned out, but you've got a P&L leader or a clinical leader with budget who wants to have some change, and we think we can completely progress that, is really, really important in the early days. And then I always say when you have that wedge point, V2 for a strategic and back to payer, provider, et cetera, is like, how do we create a string of wins and then roll out platforms that have multiple use cases? And I think certain key areas, if you're a provider, I think you're gonna have certain platforms with use cases in. And V3 to me is once we've gotten like the individual use case, the work group use case, if you will, another way to think about it, actually a CTO from a payer said this to me this way and I loved it. V3 to me is how do we now change